Belonging to Wiradjuri families and country, I acknowledge the traditional custodians and spirits of the land, air, and waterways. I acknowledge science, health, design, and environmental management, all practiced before colonization. I see these knowledges, that they're being overlooked as part of the unfinished business that doing an acknowledgement of country now signifies, and that the elders of the past did not give up their ownership or custodianship. This always was, and always will be, Aboriginal land. I acknowledge I am just a visitor here, though I'm making it my home. I acknowledge I benefit from the great pain the traditional owners went through and go through, and I acknowledge their welcome to country and how clear they are about what they expect of me. As the next generation of leaders, may all of us on this land do as we can to share power and resources, to really back what the elders and leaders of today ask. May we do all we can to get ourselves informed about principles and practices they already have and do, and that they implore us to use. Let's get right-sized for country. We are tiny in the scheme of it. Let us find and feel that humility, acknowledging we are totally dependent on it for every breath in our lifetimes.
Welcome to this first Thought Leadership for Insight. Insight is a new pan-university institute at UTS, which is looking at solving some of the entrenched health issues that we struggle with in terms of our population well-being. I'm also wanting to add my acknowledgement of country to that you've seen played already. So I acknowledge the Gadigal people of the Eora Nation and acknowledge the elders past and present, acknowledging them as the traditional owners of this land that we're privileged to work and stand on today. So I'm the inaugural director of Insight. I've been in Sydney for about a year and we've just launched Insight. What I want to talk to you about today is where I've come from, the 2 decades of work that I've undertaken as the leader of a Growing Up in New Zealand study, a longitudinal cohort study in New Zealand. And that's a study that really was designed to translate evidence, to provide evidence, and to have impact in terms of improving well-being of generations of children and families who are growing up in New Zealand, but equally it has applicability to what's happening in Australia. So I want to take you through the journey that I've been on in leading that study for the last 20 years. And try and show you how we hope that we will be able to emulate some of that journey as we set out on our Insight journey. So what is Growing Up in New Zealand? Well, it's a longitudinal cohort study, which means that we're basically following the same children and families over time. In this case, we started with nearly 7,000 children and their families, and we started before they were born. So the idea was that in New Zealand, while we might think it's a great place to raise children, our statistics about how our children are doing tell us a different story. And they tell us about vast inequalities that we see between subgroups in our population. And actually, despite the best efforts of researchers and policymakers to change those statistics over time, those statistics were becoming entrenched. And so 16 government agencies got together in New Zealand in the very early 21st century and said, we really need another longitudinal study that can help us understand what is going on for our population. Why are we not managing to change their health and well-being? Because that's actually impacting on all of our well-being. So this study was set up in conjunction with 16 agencies who said we need to follow children from before they're born and follow them over time to understand what is shaping their well-being in 21st century New Zealand. Now, New Zealand has a great history of longitudinal studies. It has a Dunedin study and a Christchurch study, both of which began in the 1970s, and they had around 1,000 children and families in them. But of course, New Zealand has changed dramatically since the 1970s. Firstly, it has a much more diverse population, so ethnically diverse and culturally diverse than it was in the 1970s. Secondly, the whole environment has changed, both within New Zealand but also globally, which means that the impacts of the environment on the development of our children and families is going to be different than it was 40 or 50 years ago. So there was a need to actually say, we need to know what's happening in the 21st century New Zealand, and we want to start another study that's going to help us understand that. We realised that in starting that study, because we needed to capture diversity, we needed to start with more children than 1,000. So we actually aimed for nearly 7,000 children so that we could capture the ethnic and socioeconomic diversity of the children and of their families who were having children in the 21st century in the New Zealand context. So what we actually set out to do was to replicate the diversity of the current births, and that meant that we were after 1 in 4 children who would identify as Māori, so the Indigenous New Zealander, 1 in 5 around who would identify as having a Pacific Island origin, 1 in 6 who would be Asian in origin, because our New Zealand Asian population had been increasing dramatically over several decades. And we actually managed to achieve that in the group that we recruited on board, although we didn't know that until the children were born because we recruited in pregnancy. We also recruited the dads from pregnancy as well, because dads matter in the life of a child from before they are born, and we wanted to capture the stories of mums and the children, but also of the fathers and the rest of the family who are involved in shaping the environment for the children. We saw the children, or the mums and the dads, first of all in pregnancy, and then we followed them up over time. So the children are actually now around 15 years of age, and we followed them up in their first 2,000 days around 4 times. So at antenatal, around their first year of life, at 9 months, at 2 years, and then at 4.5. And we followed them up subsequently at 8 years and 12 years, with a few electronic captures in between. I'm going to tell you about some of the things we've learnt from that. I guess one of the things that was different about growing up in New Zealand, though, from the beginning, is that we wanted to do things so that we could actually find out how to improve well-being of this generation of children, and hopefully of generations to come. And so we set out to find out what works to actually shape well-being, not just what doesn't work. So that meant actually establishing relationships with those 16 government agencies and the research team right from the beginning. Now, finding evidence about what works is actually not as straightforward as it sounds. And when we think about the way that we normally do research and provide evidence to inform policy, we're often looking at what risk factors we see, because risk factors for poor well-being is what we collect most often. So we had to think very carefully about how we could collect information differently that could help us provide evidence back to policymakers across multiple sectors about actually what was shaping well-being, what created the environment that would allow children being born in New Zealand today to thrive. So we actually set out to do that slightly differently than we might have done in a longitudinal study that existed elsewhere in the world or earlier in New Zealand. We also wanted to get beyond this idea that just understanding how strong an association is between a risk factor and a particular outcome is somehow enough to tell us what to do to make change. Actually, it's not. It's necessary, but it's not sufficient. We need to understand actually how things work in reality. Lives are complex. Usually risk factors accumulate, they cluster, there is a temporal dimension to the way that things accumulate over time. And we wanted to be able to set out a study that could actually find out what was happening for these families and children and how we could understand what might work to support them better, which meant setting things up differently than we might have if we were just thinking about a cross-sectional study or thinking about a study that was just looking at one outcome or one risk factor. We were interested in all of development, so that was something that challenged us from the beginning. We also wanted to have impact. Now, impact is a loaded word in research, and actually when we talk about impact, as we all do, we often have to say what sort of impact we think our study or our research is going to have before we even do it. And the reality is that it's quite rare that one study can actually have impact. This is a lovely cartoon that comes from John Lynch, who was at McMaster, but he's an Australian who's now back in Adelaide University. And he tried to illustrate the complexity of having impact from research, or if you like, translating evidence from research into the policy context. And you can see this is a really busy cartoon. Impact is not linear. Impact doesn't happen because of one result. Impact is likely to happen because of a number of results that all point in a particular direction. And impact will be different according to who's looking at the actual results and what they are looking for. So we wanted to think about impact before we started, but we also recognised that it was a complex thing to capture, but we wanted to try and do that as we set up this study. So how did we do that? Well, we did it by taking this life course approach to wellbeing, or a social determinants approach. When we thought about our nearly 7,000 children growing up in the context of their family, we were interested absolutely in the children, in what was going on for them, how their development was changing over time. But we also recognised that children don't grow up in a vacuum. They exist in dynamic interaction with all of the environments around them, starting with their immediate family and their household, and they're going all the way out to formal and informal societal organisations and out to the policy layer at a national or global level, which is designed to be impacting those children and families, but which you can see on this diagram illustrated by the red arrow, that often there is a gap between the best intention policy and actually what is happening at the level of the children and their families. So we wanted to set up a study that could follow the children, measure their development, their well-being over time, but equally could understand what was happening in all of those environments around them, a little bit like layers of an onion, all intersecting and engaging with each other over time and all changing over time, not just the child, but the family and the environments around those children changing too. So at every time point we engaged with those families and children, we wanted to be able to measure what was happening in those environments around them, and then be able to understand how those changes, as well as the environment at a particular time, might impact well-being of children at different points in time. As I think you can see, this is a double puddle model. That's what we affectionately call this conceptual framework that sits behind everything we do in this study. It means that things aren't static, they are changing over time, and we're very much interested in understanding the temporal dimension in a longitudinal study. How do things change over time? How does something that might be a risk factor become an outcome? And how does an outcome become a risk factor over time? So very different than the sorts of ways that we might look at a cross-sectional study. So we were very interested in tracking all of these things for our children from before they were born. Because we were also determined to actually explicitly provide this information to policymakers and to multiple policymakers, we set up relationships with those 16 government agencies from the beginning of the study. So throughout the design phase, as well as the data collection, the analysis, the reporting, we were engaging with 16 government agencies to find out what their needs were in terms of information that they could use to inform policy. And when we collected the evidence from the families, we would then go back to those agencies and say, this is what we've found. How can we report this or present this to you in a way that is useful for you to use at the policy table? And so you can see that those partnerships weren't just at the end of the research, when we think we've got something to say or share from a robust scientific approach, but we actually work with these policymakers all the way through, which, yes, was an additional challenge, but actually was a huge opportunity to ensure that the lived realities of our families could actually be taken to the policy tables. So after all that, what did we actually find? Well, as I said at the beginning, we focused a lot on the first 2,000 days for these children. Between the time that the original New Zealand longitudinal studies in the 70s had started and the 21st century, a lot more emphasis had been put on the developmental origins of health and disease. The idea that a trajectory of development for a child starts well before that child is even born and actually changes dramatically over the first 2 years of life. So we were committed to actually understanding what was going on for the children but also in all of those intersecting and overlapping environments at 4 time points in those first 2,000 days to really capture change and what was happening for the children and how that impacted on them. So I'm just going to summarise some of the key things that we found in that first 2,000 days. And this comes from hundreds of outputs. And I call them snapshots because actually these are snapshots of people who are in our cohort. We have around 50 families who are part of a group called our Leading Light group. And they are a group who lead the way for the full cohort of nearly 7,000 in that we test out what we're going to do and we hear from those families about whether the way we are collecting data and interacting with them is actually working for them. And that means that we can then adapt what we do for our other nearly 7,000 families and hopefully capture the information that the families want to share with us, but that also our policymakers want. So this first picture, the snapshot that I show you, is to remind me that actually we're going to focus a lot on mad, sad and bad, on what goes wrong, because that's what we tend to do in research. But actually 80% of our children are happy and healthy by the time they are 4.5. That's what the parents tell us. They tell us they are happy with how their children are doing, which is fantastic. So 80% of the families report that their children are happy and healthy as they are about to enter school. Also, what this picture reminds me of is that 98% of all of our 4.5-year-olds were in early childhood education of some form before they started school, which actually hits the targets that our Ministry of Education is looking to hit, with all 4.5-year-olds being in some form of early childhood education before they transition to formal education in New Zealand at 5. But actually, there's a vast range of what that ECE environment looks like, and that's a whole other story that I won't go into today. Let's go to the mad, sad and bad. Let's start with the mums. Some of the things that I'm going to show you are really the things that stood out because they shocked us, and here's one that really did. We looked at depression in the mums. We also looked at it in the dads, actually independently, in pregnancy. So we used a standard Edinburgh depression score to actually measure how mums were doing, how their mental well-being was, at around about 28 to 32 weeks of pregnancy. We were absolutely shocked to find that 1 in 8, 12% of our mums in late pregnancy had symptoms that suggested they were depressed. Now, this is a screening tool, which doesn't necessarily mean they were depressed, but 1 in 8 is huge. And certainly when we looked further, we found that at least half of those mums had not been acknowledged as having a depressive illness and had not been treated or were not being treated for that depressive illness during pregnancy. Now, that number postnatally dropped to 1 in 12. So you could say, well, things have got better. But actually, they were a different group of women than the women who had problems antenatally. So around half had stayed with problems that persisted, and the other half had resolved, and a new lot had then developed problems at 9 months in the postnatal period. So actually there are huge issues about under-treatment, under-recognition of depressive illnesses for mums in pregnancy. And when you think about the impact of that on the environment that they are going to be able to provide for their child, the child that they are desperately wanting to give themselves to, and recognising that their mental well-being is not as great as it might be, then that is a shame. That is such a missed opportunity for us to actually be intervening before a child is born and actually giving that mum and the child the best chance to be in the best mental health when the children are born and in their first few months of life. The other thing that we did that was a bit novel is we actually asked the dads about their depression as well, and we asked them independently of the mums. And actually 5% of the dads also had depressive symptoms, which is higher than men of the same age in the population who are not actually going through the birth of a child. So dads actually get the blues a bit more than men do of their own age when they are expecting a child as well, which is a different finding than we've seen before. When dads got the blues, that meant it was more likely that mums were depressed. When mums were depressed, didn't seem to make any difference to dad. So go figure. We also then looked at the children. So one of the other things that we were a bit shocked by actually, and we were shocked because of the proportion of children for whom this was reported. So we asked the mums about various things about their children because at 4.5 the mums were telling us about the children directly. And 1 in 3 of the mums told us that their children were regularly bullied by their peers, not at home, but at other environments, ECE environments, for example, or by others that they were in connection with. 1 in 3. And we thought, oh, this is just mums being a little bit precious about their children. They also told us that 10%, or 1 in 10, had been bullied right throughout their preschool period. So we were really shocked by this. We were worried, but we were also thinking, maybe this isn't quite accurate, and let's see what the children tell us later. And I will tell you what the children told us themselves when they were slightly older. But 1 in 3 bullying is a horrific statistic. We also know in New Zealand that when these children become teenagers, they have some of the highest reported rates of bullying in the OECD. So maybe, just maybe, this is the beginning of when bullying starts, and actually it's tolerated, which is an awful thing to think about in our society as well. We could also look at things like engagement with existing services, social services, health services, and we could ask the parents directly about whether their children had engaged with services, and if so, why, and if they hadn't, perhaps what were the barriers or the enablers to those services. So in this case, we have free dental service that's available in New Zealand for our 0 to 4.5-year-olds. But actually, despite it being free, only 70% of the entire cohort had actually taken up that free offer of a free dental check before their child started school. And when we looked at our Māori and Pacific children, the rate was less than 50%. So there was something about that told us that it's not about the cost of these services, it's something else going on with these services. And we investigated that a little bit more to find that mostly the reason that people weren't engaging is because their services were not seen as either acceptable or accessible to some families. So that was something that we've done some work on, and I'll share with you as well. Finally, this isn't a photo because it is about a really sad part of life for some of our children, and that is the experience of physical violence between parents. So we asked about many markers of relationship status, of relationship violence, if you like, that is physical, but also could be emotional or psychological. And in the case of interparental physical violence, we also asked whether the children were present when that violence was occurring. And really sadly, some 4%, or 1 in 25 of the children out of 7,000, were regularly present when their parents were actually experiencing physical violence between each other. And that's a really also a very sad indictment on what is going on in these homes, and also potentially linked into some of the bullying statistics that we see in these families. So those are some of the raw facts, and I'm going to get into some of the things that we did with that and how we translated what might work in those situations shortly. But I just want to touch on another couple of things that we fed in from this first 2,000 days of evidence, and that is really sort of around the idea of busting myths. So a lot of policy, a lot of well-intentioned policy is based on an understanding or an assumption of what is going on out there in lived realities for families. So we wanted to actually look at that because we'd actually asked families about things, about their intentions to do things for their children, and we asked them before those children were born, so we could ask them in pregnancy, for example, do you intend your child to be fully immunised? And do you hope that those immunisations will be on time? Because basically what we knew from our statistics is that we have a group of children in New Zealand, particularly our Māori and Pacific children, and those who are experiencing the most socioeconomic disadvantage, who actually fail to get their immunisations on time. They fall behind their peers, and because of that, probably causally, they are more likely to end up in hospital with avoidable illnesses, often respiratory illnesses. So we wanted to challenge whether that was actually because they didn't know or because something else was going on. Because the assumption often in policy, in the policy world, or even from the academic side, is often, well, let's just tell people about it. Let's just educate them about the benefits of immunisation. And then the parents will go along and be more convinced that that's what they should do. So we looked at what happened for these families. We asked the mums and the dads, do you intend to fully immunise your children once they're born? And this is the result that we got, the one that's actually in the red oval, that happened in pregnancy. So this is before the children were born. We asked the mums and the dads independently, And actually our Māori and Pacific mums, and also those who were least advantaged, actually had the highest intentions to immunise their children, to fully immunise their children after birth. But actually what happened by the time we followed those children up over the first 3 periods of time in that first couple of years is that the Māori and Pacific children had the lowest rates of immunisation by the time they were 9 months of age, and they had the least timely completion of immunisations. But basically this was telling us this is not about a lack of knowledge. These people want their children to be immunised. This speaks to the inaccessibility and the lack of connection of these services to the lives of the people for whom it matters most. And so this was information that we could feed back and say, this is not about giving out more education. This is about redesigning services and taking them to those families who need it most. We also looked at things like the parental view. This is about obesity. Unfortunately, we have 1 in 3 children under the age of 15 in New Zealand who are overweight or obese. When we look at our children in their first 5 years of life, we see that by the time they're 4.5, we had 14% in the Growing Up in New Zealand study, and that was up from 9% when they were 2. We measured the children directly at home, so the interviewers went to the family home and they measured them using the same process that the Ministry of Health uses to collect BMI. So actually that was worrying, firstly, that we were seeing this increasing trend over time, 9% at 2, 14% by the time the children were 4.5, potentially increasing up to that 1 in 3 by the time the children are adolescents. A couple of interesting things about that. The first one is that when we do cross-sectional looks at that using routine data, it looks like the rates of obesity and overweight in our children are dropping. That's just because of the children who are being captured in those routine data. When we follow the same children, we're seeing increasing rates of overweight and obesity. The second thing is that we were able to ask the parents what they thought about their children. Did they perceive them to be overweight or obese? Because actually, unless you perceive there is a problem, you're unlikely to do something about it. And actually, that's where we saw this worrying gap. The parental perception of those who were overweight, while it was 14% when it was measured, only 5% of those parents actually thought that their children had a problem. The rest actually thought that their children were happy and healthy and doing well. So they're not going to make any changes to the things that they do with their children if they don't think that those children have a problem. Normal weight was fine. The other thing that was slightly interesting, perhaps slightly concerning, is that 10% of the parents thought their children were underweight. Actually, none of them measured underweight. In fact, it was 0.3%, so virtually 0% of the whole cohort measured as underweight. But actually 1 in 10 parents thought that their children had a problem with underweight. So this perception is really important, because if you're being given advice by health workers or by others to actually say this is what you need to do to make change for your children's well-being, if you don't perceive a problem, the chances are you're not going to make a change. So really important to understand the parents' part in this. One thing that I've kind of alluded to and we looked at in multiple ways was who was actually engaging with the current services that were on offer for our preschoolers. And unfortunately, we saw the inverse care law well represented in whatever service we looked at for these children. When we linked in, we saw that those who were most socioeconomically advantaged had the greatest access to services, although they had the lesser need in terms of actually thinking about whether they really needed those services. And at the other end of the scale, those children who had the greatest need were actually engaging proportionately less. The other thing that we saw is that around 10% of the children who were in the cohort weren't engaging with any of the services. So they weren't even being counted. And so as services are redesigned, we look at the administrative data, we look at those people who engage with the current services and we try and make those services better. The reality is that we are perpetuating the inequalities by doing that, by missing out these people who actually don't engage with the services at all, who have the greatest need and who actually are not being serviced currently by those services that are provided. Okay, so as well as these bits of evidence busting the myths and thinking about some of the snapshots that we saw, one of the other things that we did, as well as all of the academic papers that we provided, is we wanted to provide this policy relevant evidence the whole way through to our government agencies, some of which was a full report, others bespoke. And this was something that challenged us really, because as academics we like to write and talk a lot. And basically we had to provide succinct evidence back to policymakers in ways that they could utilise at the policy table. So we created these policy briefs. We started to look at particular issues that were of note and of importance for the government of the day. So here's just a few examples of those. We looked at nutrition, for example, in pregnancy, and we looked at the fact that actually women are bombarded by messages about what not to eat in pregnancy, and there's very little evidence out there about what they should eat, and actually it's very confusing for people. So we tried to actually say, could we not make this simpler for people? We also looked at what was happening with folic acid in pregnancy, and we saw that actually only 1 in 6 women were taking any folic acid, and only 3% of women were taking it correctly. So that led us to work with the people who were creating fortification or thinking about fortification of foods, and folic acid is now added into bread, which has made a big change and meant that people who could not get folic acid because it was expensive can now access it through eating their staple diet, which we also knew they were eating more of for those that needed it most, if that makes any sense. We looked at safety issues because we have a huge issue with driveway accidents in New Zealand and drownings, actually, the 2 biggest killers of our under 5-year-old children. And we wanted to understand what was going on in the homes of these children, what was the safety of the environment. And one of the things that we found is that people in rental properties, and there were 40% of our families in rental properties, actually had the least control over their environments, and those particular environments were much less likely to have fewer safety features and fewer safe places for the children to play outside of the house. So that sort of evidence actually started a warrant of fitness for landlords, which has now been put into place to actually ensure that landlords are responsible for making sure that there are safety features in rental homes that otherwise people who are moving quite often between those homes don't have control over. The last one that we looked at, and it's a big one, is child poverty. Now, child poverty is obviously an issue right around the world, but it was a huge issue within New Zealand for the former government under Jacinda Ardern. And so we wanted to be able to help to provide evidence from what we'd seen from these 7,000 families about what they were telling us about the environments that their children were growing up in. So we could look at poverty in a slightly different way than governments usually look at it. Usually poverty is measured by some sort of income measure, or it's measured by an equivalised household income sometimes, where it accommodates the number of people in the house or the number of earners in the house. But ultimately it's usually sort of one statistic that is used to cut off who is in poverty and who is not. Sometimes it's about employment, other times it's about the area that you live in, socioeconomic status. But with a longitudinal study, because you're engaging with families and actually collecting multiple pieces of evidence over time, we can get a much richer view of what poverty might look like for children. And that's actually really important in the first 2,000 days as well, because when you think about things like income, many people will actually give up work when they have a young child. And those who have no income are usually wealthier than those who have some income in those very early months. So you've got all sorts of things going on like paid parental leave and other issues, which mean that those traditional measures of is a family living in poverty are actually a little bit difficult to make sense of in that first 2,000 days. So we used instead these 12 measures of capital. Economic capital, absolutely important for the development of child, but so is social capital, so is physical capital, the quality of the home that the children are living in, the environment that they're existing in. And we looked at all of these capitals together. So we were able to measure those over time for these families using these 12 characteristics of the family, some that were very close to the family that we called proximal family variables, some that were a little further away, distal family variables, and then some that were about the home environment themselves. And we had these 12 factors that we'd measured for the children before they were born, and we'd measured them in their first year of life around the age of 9 months, and we'd measured them again when the children were 2. So we could look at how these 12 factors were distributed across our 7,000 families and understand actually how they clustered and how they accumulated over time, rather than just looking at one particular feature. What we saw probably wasn't a surprise when we looked at how these clustered and accumulated, and we simply did it by adding the number of these 12 factors that any child was experiencing at each of 3 time points. So technically they could have experienced up to 36 of these different deprivation measures. That would have been extremely rare, and it was extremely rare. You can see from this graphic that most experienced between 0 and around 15 or 16 of those things when we actually added them up over time. What we can see in this graphic, though, is that when we broke that down by the ethnicity of mum, we can really see some different distributions going on for these children. And it starts to perhaps get at why we see Māori and Pacific children in New Zealand doing so much worse than their European and Asian peers. It's not just about one thing acting at one time. It's about accumulation and clustering of exposure to disadvantage. And we start to see these different distributions of exposure to huge burdens of disadvantage for our Māori and Pacific families that we don't see for our European and our Asian families. What we did is we simplified that further, because we're all for making these simple messages, particularly when we're translating across to policy. So we just looked at high exposure, which we took as being 4 or more of those 12, any 4 or more at one point in time. And then we looked at medium exposure, which was experiencing between 1 and 3 of any of those 12 risk factors, and low is experiencing none. And then we looked at adding those up over 3 points in time. And we wanted to see what happened for children who experienced those different patterns of disadvantage right across their first 1,000 days. Where were they at 4.5? So what was their status in terms of their development and well-being? So basically we set out these sort of graphics that looked at this gradient of impact of being exposed to greater or lesser burden of disadvantage, of greater or lesser clustering and accumulation of burden. So you've got on the bottom of this graphic those who experience no disadvantage at any point in time from pregnancy, 9 months or 2 years, right across their first 1,000 days, compared to at the top where you've got children who experience disadvantage 4 or more of those 12 risk factors at every single time point across those first 1,000 days. And in between, you've got graded exposure to high or medium disadvantage at each of those time points. And I hope what you can see in this graphic is a graded relationship with how these children are doing. So this particular characteristic is obesity and overweight. It's looking at physical well-being, if you like, at 4.5. And we see this graded impact of disadvantage across that first 1,000 days on where these children end up by the time they're 4.5. And we see that the risk is, 3 or 4 times greater if you are exposed to these disadvantaged environments repeatedly or persistently as compared to those children who've experienced none. We also put in emotional, psychosocial, readiness for school measures, virtually anything you could think of into these sort of graphics. And here's one more just to show you. But we could have looked at any number of these and we see the same sort of patterns. This is a pattern that looks like abnormal behaviour for children at 4.5. Now, 4.5-year-olds, we'd normally expect around 10% on a screening tool that looks at STQ to identify that they might have abnormal behaviour. That means not such great self-regulation, self-control, the ability to engage with their peers and so on. So a number of characteristics that are actually really important for how a child will do when they enter formal schooling. In this case, we see an even greater spread, a bigger gradient, if you like, between those who have been exposed to the greatest disadvantage and those who have experienced none. 10 to 11 to 1 in terms of 44% in the highest group versus 4% in the lowest. And remember, that's 10% across the population that we'd expect to see. So we're seeing the impact of poverty in those first 1,000 days already setting children behind their peers before they even enter school. And it's not just on one developmental front, it's on virtually every front that we think about. When we think about literacy, when we think about numeracy, when we think about readiness to learn, we see the same sort of gradation that is shaped by social disadvantage in this case and by persistent poverty. So We could have left it there and said, okay, we've found out that poverty is bad. That's not a big surprise. Poverty is bad. We've demonstrated how bad it is in this collection of longitudinal information. But we wanted to set out to provide evidence to inform wellbeing, to understand what we could do to actually help children to thrive despite them being experienced to these disadvantaged environments. So we turned the evidence around, and those graded diagrams, yes, there were more children from the more disadvantaged groups who were showing these poorer outcomes at 4.5, but not every child was. So for the 44% that we saw that had abnormal behaviour, 56% actually had normal behaviour. So something was happening for those 56%, or almost half in every case, of the children who weren't experiencing poor outcomes. They were thriving despite these socioeconomic conditions. Now, the first thing to say is that's not to excuse the socioeconomic conditions. We still have to think about how we ameliorate poverty, but it's a big task and it's going to take a long time. So we wanted to say, well, what can we do in the meantime? What can we actually do to help more children to thrive while we try and fix this environment that is broken in terms of poverty and socioeconomic disadvantage? So we wanted to move beyond this idea of just risk factors and understand what may be shaping resilience for these children. So that's what we did next. So we did that because we could go to 1,252 children in our cohort who were growing up in some of the most disadvantaged spaces in New Zealand, a place called South Auckland, where 80% of the children lived in significant disadvantage, and around 80% were also Māori or Pacific, who we know were experiencing the worst outcomes. So we looked at the data for those children, and we looked at what actually meant that some of those children were thriving. We used the evidence from those families directly, but we also worked with those communities to help us understand what those stories were telling us, rather than just looking at it from an academic point of view. So South Auckland, very disadvantaged community, but when we looked at the evidence that they had given us, they'd gifted to us, if you like, in this longitudinal study, we could see there were things that actually helped to protect their children. And those things were pretty simple, actually. They were things like connectivity to your community, good relationships within your family, being well connected into services and feeling like you belonged in your community. Having a strong sense of cultural identity was also part of the deal. Those were the things that seemed to exist in the families of children who thrived despite experiencing the same disadvantage as their peers who went on to have poorer outcomes. So we looked at what we could do with those factors. And again, because we're academics and we sit in our ivory towers and we don't necessarily know what the real world looks like, we went to the communities and we said, this is what your stories are telling us. This is what we think you are telling us in terms of what might protect your children and others like them. What should we do with this? How do we work with this to design services that are actually going to hopefully help to improve the well-being of your children and others? So we worked with the City Council, Auckland Council, and we also worked with the local libraries. And they came up with this idea that we could create loud libraries, this idea that libraries could be a safe home away from home for these families, a place where young families could gather, where services could come to them instead of them having to go out and reach out to multiple services, and a place where they could support each other as they raise their children. So those seem really simple sort of ideas, but they've come from this powerful set of data that these families have shared with us that tell us that these are the things that are likely to make change. So we're just looking to see how those things play out over the next decade or so, while still trying to solve child poverty. The last thing that we did using all of this information, and there are hundreds of outputs that came from this first 2,000 days, was we actually worked with all of the social wellbeing agencies as well to try and understand how we could support families with young children better across their first 2,000 days. So we came up in the end, after going through thousands, literally, of pages, with an A3 summary sheet that we worked with social wellbeing agencies on to try and say, this is how you can use the best evidence from international studies, and this is how we can use our own local reality from the Growing Up study. And we can tell you, we can hopefully work with you to actually see how we can put in place support systems and services that might actually help all of our children to thrive, that are not just based on risk factors, but they're based on what creates resilience. So there's all of this work out there that talks about things like inviting fathers to antenatal visits, talking to them about immunisation as well as mums, thinking about extended families, because most of these children don't just live with mum, they live with dad, they trust auntie, they trust grandma, they trust their friends, they don't necessarily trust the health professionals. Setting up early childhood centres and other services that are culturally appropriate and accessible for these families. So a number of things that we worked with over a number of months to try and actually make sure that the lived realities of these families was actually informing the policy context that we'd set out to in the beginning. So that's the preschool period. I want to tell you briefly about what happened next, because it's kind of exciting, I think. It's a time when the children were 8 and they were able to speak for themselves. So this was really exciting because it wasn't their parents telling us about how their children were doing, it was them themselves telling us about their well-being, what mattered to them, what they thought about bullying, which I'll tell you about shortly. So the children had their own questionnaires at 8, as well as mums and dads telling us about how they thought their children were doing. They also had time use diaries. They told us what they were doing, a day in the life of an 8-year-old. They also had little temperature monitors, which they took into their schools and their homes, and they measured how warm or how cold, actually, their bedrooms were in the morning, during the day, when they went to bed. Really important pieces of information to help support some of the information that we were getting about how bad our housing was for these children and how that was impacting their well-being in terms of ending up in hospital with respiratory illness. So they did lots of things. They were our little scientists and they had little badges, and they kind of loved that they were out there actually helping to collect the information. So I'm just going to tell you a couple of things that came out of the age 8 wave. One of the first things is that identity is such an important part of well-being. We kind of heard about it a bit when we were looking at whether people felt like they belonged in their community. Did they feel safe? Did they feel they belonged? It's important for children too. And at 8, we were really interested in the beginning of the emergence of their identities. So we wanted to know about their cultural and ethnic identity, but we also wanted to know about their gender identity. We also wanted to know about their body image, so we asked them about things about how they saw themselves and how they thought others perceived them, because we were trying to get to the bottom of what was going on with this bullying statistic. And what we actually saw is that our Māori and Pacific children were much more likely to actually understand who they were and what their identity was. And that was really important for their well-being, actually. Around 7% of the children actually didn't have any idea which ethnic group they belonged to, which was interesting, but mostly those tended to be our New Zealand European children because they hadn't thought about it. They hadn't been talked to about it by their parents, whereas our Māori and Pacific children and our Asian children too were more likely to be able to say who they thought they were. Now, interestingly, they didn't always think they were the same ethnicity as their parents had told us they were going to be. So that's interesting too, because when we think about statistics and we think about health statistics and we think about inequalities, we often want to break those down by an ethnic identity. And the question becomes, which identity do you use? Do you use mums? Do you use dads? Because they weren't always the same in the study either. Do you use the one that they thought their children would be, or do you use the one that the children tell us they are at 8? Or maybe when they're 12, when they change their mind again. So this is a really interesting piece of work that's evolving, and that we're going to be able to see what impact ethnic identity, strong cultural identity has for well-being for these children. Interestingly, even at 8, even though people told us it was too early, we had almost 2% of the children who identified as a gender that was different than the sex they were assigned at birth. And around about 14% who were somewhere in the middle of thinking they were a boy or a girl. So again, tracking that development over time and what that means for their well-being and what it means for things like perception and bullying is really important. Here's the bullying stat. And this is kind of worrying. It's more worrying than the 1 in 3 that we saw at 4.5, because now at 8, more than 1 in 3 of the children are telling us they are regularly bullied. So this is a real statistic, we think now. It's not just something that's in mum's mind. This is something that is actually really worrying and starts to explain why we start to see such huge issues when our children get into adolescence. So 1 in 3 of the children are saying that they are bullied, which is a horrendous statistic. We also looked at people recognising, or the children recognising bullying in their peers and being empathetic to their peers. And actually those children who were bullied the most tended also to have the most empathy at this age. So a lot of things to learn in terms of how can we actually start to change this sort of pervasive environment that seems to exist for our children in New Zealand. So in the double puddle model, I also showed you things about changing environments around the children. So a couple of things I just want to focus on now are the household structure and the household environment, things that changed quite dramatically for these children. Because we kind of often think that it's fixed and these children are going to grow up in the same sort of families, and we don't measure it again when we're thinking about what's happening to well-being. In fact, the structure of who was in the houses of these children changed quite dramatically. 1 in 4 living with extended family and pregnancy, down to 1 in 5 by the time they started school. 10% of relationships in the first year of life changed in terms of parents. So they either dissolved or they were new relationships. So relationships around these children, which are really impactful in terms of their well-being, were changing constantly throughout this period of early childhood. And we were able to track that and find out what that meant for the children. As well as the people changing though, so was the environment. I think perhaps one of the most surprising statistics is that only 1 in 4 of all of those 7,000 children had not moved home at least once in their first 8 years of life. So 75% of the children had moved at least once between homes. Many had moved multiple times. So they've got people changing around them, and they're also changing in terms of their immediate environment. We hoped that was moving to more secure environments, maybe from rental properties into home ownership. But unfortunately, that wasn't the case. Most of the movement, most of the mobility was actually between rental properties. Now, there were good and bad push and pull reasons for moving. They weren't all the same by any means. But basically, when these families are moving and we think about how we're providing services for those families, that's a real challenge, because most of our services are defined by censuses, which occur every 5 to 10 years and track where people live at that point in time and design schools and health services and various other things. The reality for this generation is they're moving much more frequently than that. So how do we actually keep track of them? How do we design services that are going to reach them if we are designing those geographically? It also has issues because of the instability it creates for the children, and as well as the instability in the environment. And perhaps one of the biggest problems is that, particularly in rental properties, we know that our children, from the measurements they took, but also from the information that the families have shared with us, that nearly 1 in 2, so around 40%, just under 1 in 2.5, children are routinely living in damp and cold and mouldy houses. That's far too high, and they're often moving between those environments. So they are living in cold homes. And those cold homes, as well as safety issues, are most likely to be in rental properties. So we know that too many of our children are actually in homes where it's impossible to actually provide enough heating to keep them warm, and the temperatures that they took in their bedrooms are telling us that their bedrooms are cold by international standards, and we know that those actual temperatures are associated with a higher likelihood of them ending up in hospital with respiratory illness as well. This is a really complicated slide, and I won't go into it in huge detail. It's really just to say a little bit like poverty and measures that we take at face value as income tells us everything about poverty. When we look at what happens to household income for these children over their first 8 years of life, the income of their families is changing dramatically. It's changing because of changes to paid parental leave, changes to employment, changes to jobs, various things, but you can see a lot of movement in income. And if you're only looking at one point in time to say when do we look at a marker of poverty or not, that's really difficult when you just confine yourself to this. We actually work with the tax department in New Zealand to try and understand the journeys of people through the first 5 years of life with their children, so that they could think about how do we support these families better, recognising that one single measure of income at one time point doesn't capture the complexity or the change over time. We also looked at things like equivalised household income that we could look at, because we knew a lot about the homes. So it wasn't just a measure of what mum or dad were earning, it was how many parents, how many children, how many adults is this income supporting? And you can see actually that while we might split people up into high, medium and low socioeconomic status, maybe according to an area level measure about where they live, when you think about within those areas, how income is distributed, you see a vast diversity, a range of household equivalised incomes, even within what we might consider to be quite consistent categories. So really it's quite difficult to capture how complex these lives are with one or two variables, and that's why we like to look at several together. Here's a lovely diagram that I'm not going to explain in huge detail. I quite like it. It's kind of nice. It tells me about what's happening for these families between pregnancy and 8 in terms of just the area that they live in, the socioeconomic status of the small area they live in. How does that change over time? And again, when we think about routine statistics and we think about how we might be dividing up health or development, we often just take one measure of this at one point in time. This diagram should bust that myth and say things change all the time for these children in their early life. These measures are changing for these 7,000 families who are representative of all of the children being born and families around them in New Zealand now. These measures of where they live and what they're experiencing is in constant flux. And actually understanding what these different patterns of exposure mean is something that we can do with this longitudinal data. And here's just one measure of that. The children telling us who they were was one thing at 8. They also told us how they were feeling, what their well-being was like. They did their own measures of depression and anxiety. They told us about their physical well-being. They told us about their perception of their body image and so on. And one of the things that we saw was that those children who had experienced the most change in their deprivation, and particularly those who were at the lower end, who were experiencing the most persistent deprivation, had worse mental health than their peers by the time they were 8, and that was on their own account, as well as what the mums and dads had told us. So the depression and anxiety scores were already higher than their peers who had experienced more advantaged socioeconomic environments in their early years. Similarly, and perhaps worryingly given the amount of mobility, residential mobility, the children who'd experienced the most household moves, the most physical moves, also had worse scores on their depression and anxiety by the time they were 8 than their peers. So these sorts of environmental fluxes were really impacting on their well-being. Finally, in New Zealand, as in Australia currently, there is a lot of interest in defining a wellbeing framework. There's a lot of interest in understanding what shapes early wellbeing, because we know that it's associated with later wellbeing. And in 2019, the New Zealand government came out with a child and youth wellbeing framework that they were looking for every government agency to measure the impact of their policies according to the impact on wellbeing, which sounds fantastic. And that's what every state in Australia is trying to work up at the moment. The problem with that is the indicators they used for wellbeing were very infrequently measured in administrative data, because administrative data that is collected for government use across the whole population usually is focusing on what's going wrong. It's usually focusing on those who need to engage with services, whether they're social services or health services or incarceration or other things that we routinely measure. But what we could do, because we'd started this project some 10 years earlier with a framework, a conceptual framework that was interested in wellbeing, is we could actually start to provide some of these pieces of evidence back from the direct stories from the accumulation of these 7,000 families about some of these things that they actually were unable to measure using routine statistics. And those things have helped to inform what we might need to collect to measure trends over time. So that's been a really quick tour. It probably didn't feel very quick, but it's been a quick tour of many, many things that have happened over the last 2 decades in growing up in New Zealand. It's been a study that I've been immensely privileged to lead from its inception, and I remain the foundation director, and we are still looking for evidence out of it to inform policy in New Zealand, but also to think about how it might apply in other areas of the world. There's something remarkable about following the same people over time, taking the ordinary stories and collecting those stories up and actually finding extraordinary things that can have impact for policy, that can help to shape how we can look after our children better and how we can actually create better futures for all of our lives, all of ourselves. So that's what I've learnt from a couple of decades of growing up in New Zealand. Obviously, I'm just lucky enough to stand up here and talk about it. None of this would be possible without the 7,000 families who have contributed their stories and continue to contribute their stories to this sort of data collection, and to the hundreds of people who are now getting benefit out of using that information. And of course, the 16 government agencies who we continue to work with and have worked with throughout to ensure that we are trying to collect information that can really make a difference to wellbeing. And I just want to acknowledge all of those people at this point and to say that this is the sort of way that we want to now take forward in what we do in Insight by partnering from the beginning, by thinking about what works about wellbeing, not just about risk factors, and about actually doing things differently where we're looking at the sorts of outputs that can really have impact rather than necessarily just the building of our own academic careers, which, you know, is one of the things that as an academic you often have to do, but so often what drives us all is actually making a difference for our current generation and really changing the future for all of our children and our families. So thanks for listening.